Medical Hypotheses, 1992, 39, 22-29, Kaposi sarcoma and HIV. E. Papadopulos, Eliopoulos, V.F. Turner and J.M. Papadopulos. Department of Medical Physics Emergency Department, Royal Perth Hospital, Department of Pathology, University of Western Australia. Abstract, recently published informed data affords strong indication that in patients with the Acquired Immune Deficiency Syndrome, HIV cannot, directly or indirectly, be the cause of Kaposi sarcoma. This paper provides reasons for disallowing a current alternative theory that Kaposi sarcoma is due to an unidentified sexually transmitted infectious agent, and proposes instead that Kaposi sarcoma is the result of prolonged and repeated exposure to nitrites and/or semen. If this alternative hypothesis is strengthened by confirmation of its predictions, then the relationship of HIV to Kaposi sarcoma, one of the principal AIDS-associated diseases, becomes somewhat remote. This may facilitate a shift of emphasis and encourage the development of alternative therapies. A theory is a good theory if it satisfies two requirements: it must accurately describe a large class of observations on the basis of a model that contains only a few arbitrary elements, and it must make definite predictions about the results of future observations. Stephen Hawking. Introduction. In spite of the passage of more than a century since Kaposi's original description, Kaposi sarcoma remains enigmatic with its precise nature in doubt. Recently, even its classification as a malignant neoplasm has been questioned, and John Brooks, a pathologist from the University of Pennsylvania, has argued that Kaposi sarcoma is a benign, potentially reversible hyperplasia that may at times terminate in true malignancy. Summary of Kaposi sarcoma subtypes. Kaposi sarcoma is classified on the basis of pathological, clinical and epidemiological descriptions. Epidemiologically, Kaposi sarcoma occurs as sporadic, endemic, iatrogenic and epidemic disease, with obvious major differences between these subgroups. The sporadic type has a predilection for Italian and Ashkenazi Jewish males over the age of 60 years, although in a series from the Arndt Institute of Pathology published in 1959, 22% of the patients were black. This subtype of Kaposi sarcoma is associated with a near-normal lifespan. However, some cases exhibit the aggressive form, and there are cases occurring in younger patients under the age of 45 years. The endemic group, which constitutes the highest caseload in the world, occurs in eastern equatorial Africa. Here, Kaposi sarcoma affects young adults, 25 to 45 years of age, and children between the ages of 2 and 15. Any of the clinical patterns may occur in this group, and there is an appreciable incidence of the generalized variety in the young adults and children, most of whom die within 2 years of diagnosis. Prior to the AIDS era, iatrogenic Kaposi sarcoma accounted for approximately 15% of all cases enumerated in Europe and North America. These were associated with immunosuppressive agents administered to organ transplant recipients or to patients with other diseases. The incidence of post-transplant Kaposi sarcoma in the United States is 0.18-0.3% of all transplant patients, while interestingly the incidence in Saudi Arabia is considerably higher at 5.3%. Penn, who reported a series of 68 post-organ transplant cases from the USA, considered that 72% were benign skin and mucosa involved, and 28% malignant, gastrointestinal and respiratory involvement. The reason why Kaposi sarcoma and also lymphomas occur in these patients, while there is no increased incidence of the common epithelial neoplasms, is unclear. However, in a comprehensive review of this subject published in 1982, Kinlan discounted failure of immune surveillance and argued the case for a specific viral-related effect in the pathogenesis. In the early 1980s, the Center for Disease Control, CDC, in Atlanta, USA observed a high frequency, 26 cases by July 1981, of Kaposi sarcoma occurring in young homosexual men. 8 of these patients died within 24 months of diagnosis. Thus was ushered in epidemic Kaposi sarcoma, that associated with the Acquired Immune Deficiency Syndrome, AIDS. In addition to Kaposi sarcoma, many of these original patients also had opportunistic infections, and for a diagnosis of pneumocystis carinii pneumonia, PCP, was made by open lung biopsy. At this very early stage in the evolution of the syndrome, AIDS, for all practical purposes, consisted entirely of Kaposi sarcoma and PCP. In 1982, Robert Gallo, who had spent many years researching retroviruses and cancer at the National Cancer Institute, proposed that the cause of AIDS was a retrovirus. In 1983, Luc Montagnier and fellow researchers at the Pasteur Institute detected a retrovirus, presently known as human immunodeficiency virus type I, HIV-1, in the cultured T cells from a homosexual patient with lymphadenopathy. With few exceptions, the hypothesis that the causative agent of AIDS is HIV has been universally accepted. However, as early as 1984 it became apparent that HIV does not exist in the cells from the lesions of Kaposi sarcoma, and hence cannot cause Kaposi sarcoma directly. It was assumed then, that in AIDS patients, HIV indirectly caused Kaposi sarcoma, and opportunistic infections by its detrimental effects on the immune system. Alterations in T lymphocyte subsets, T4 and T8 cells, and a decrease in the T4/T8 ratio were believed to be the hallmark of AIDS and the immune deficit that defined this condition. However, in heterosexuals, evidence existed that many diverse causes could be associated with the same and additional laboratory abnormalities of immunodeficiency that were manifest in AIDS patients. These causes included a number of infections, blood transfusion, the intake of many drugs including antibiotics, and even solarium exposure. It is noteworthy that in none of these reports was there a single case of associated Kaposi sarcoma. Conversely, some researchers at the time were of the opinion that Kaposi sarcoma could result from immunostimulation with angiogenesis-promoting factors formed as a result of alterations in immunoregulation, a mechanism that had been earlier suggested in patients receiving immunosuppressive therapy. As recently as 1988, researchers from the Walter Reed Army Institute of Research, disallowed Kaposi sarcoma from the definition of AIDS, stating that, quote, in our system the presence of opportunistic infection is a criterion for the diagnosis of AIDS, but the presence of Kaposi sarcoma is omitted, because the cancer is not caused by immune suppression. Most recently, data has been published confirming the fact that in some homosexuals Kaposi sarcoma can occur in the complete absence of both immune deficiency and HIV. Thus neither HIV nor immune deficiency is a prerequisite for the development of this disease, at least in homosexuals. Despite all this uncertainty, acceptance of HIV as the cause of Kaposi sarcoma prevailed for over 6 years until early 1990. In January of that year, Valerie Burrell and her colleagues from the CDC published a paper, in which they concluded that Kaposi sarcoma in persons with AIDS may be caused by an as yet unidentified infectious agent transmitted by sexual contact. This argument was based on the epidemiological spectrum of Kaposi sarcoma in different age risk groups and the fact that in homosexuals Kaposi sarcoma may appear in the absence of HIV. This conclusion, to which we cannot accede, is based on the author's assumptions that a. The agent that causes Kaposi sarcoma must be the same irrespective